Well, thanks so much for having me. This is like a very fun talk for me. At the university, they really like us to talk a lot about cutting edge research or something very specific. But here, what I really enjoy about my job is I get to sit in the rooms with people, with patients, and discuss lung disease. It's like that's where I'm passionate. I'm 100% clinician. I don't do research as part of my career. I do a little bit of teaching, but primarily what I spend all my time doing in my job every day is sitting in the exam room or rounding in the hospital taking care of people with lung problems. And so for me, this is like such a fun talk for me because I get to do the thing I love to do, which is sit here and talk to you guys, which is great. Now, lung transplant is a pretty specific topic. We have to remember the lung transplant is the right thing for a very few number of people who have chronic lung disease. But still, I think it's nice for y'all just to hear about it, give kind of an overview of it, and get a sense of what it takes to become a candidate for a lung transplant if that's something you're thinking about. So that's kind of the goal of what I have for you guys today. Super interactive. Stop me anytime. Raise your hand if you just want me to stop, or something on that slide was you want to hear more about. I'm happy to do that. And we probably have too many slides than we have time, so the stuff at the end isn't that important anyways. Okay. So this is a kind of a blurry graphic. I don't want to cut off the side, but the number of lung transplants done in the world every year, with green representing North America. You have to remember that Canada does a pretty good number of lung transplants as well, but still North America makes up the most number of lung transplants in the world. And you can see this really gradual but pretty progressive rise in the number of lung transplants done every year. Now, in the world, we exceed 4,000 transplants. This is from 2023 is the last time this was updated. But now in 2025 and going into 2026, the world exceeds 4,000 lung transplants done every year. That's still very small compared to other solid organs such as heart, liver, kidney. And you can see that rise has primarily been in North America, where we're gaining a lot more experience compared to the rest of the world. But it started in Canada. I think we just gained more experience here, and I think also in the United States we just culturally have approach of being slightly more aggressive about healthcare, and kind of lung transplant's a pretty aggressive kind of step in treatment, and so it's been more popular in the United States than it has been in other countries. Good question. In the United States, we currently have 73 active lung transplant programs. 8 of those are pediatrics, so I won't apply to anyone in the room. Not many pediatric lung transplants are done every year. Just it's very rare surgery, with most of those programs only performing a couple every year. So we're talking about 10, 15 pediatric transplants done every year in the world. But 65 adult programs, and then you can see the size of them there, with 7 programs doing above 100 transplants a year. So those 7 programs make up kind of our big programs. Within the next stage is where Colorado lands in kind of this 50 to 99 range. We did, I think, right around 50 last year, maybe 50, 48 last year, 52 the year before that. I forget the exact numbers, but we've been around 50 the last 2 years in a row. 17 programs between 25 and 49, and then 20 programs are on the smaller side, doing less than 25 transplants a year. Who gets lung transplants? Well, since 2012 to 2024, the most common group has been those with interstitial lung diseases, or what we call restrictive lung diseases. Okay, this is things like pulmonary fibrosis, and makes up now about half the transplants done every year are done for interstitial lung diseases. Obstructive lung diseases are next. This is most commonly COPD, or smoking-related lung disease, which makes up those blue circles there at about 700, 800 transplants every year. And then we're going to talk a little bit more about cystic fibrosis, which is a disease of younger people, and then pulmonary vascular disease, which has some new good treatments coming out for it. It's overall rare disease, so not as many transplants are done for that indication. This is the cool drop off from cystic fibrosis, but here again, you have years on the bottom, number of transplants done every year at the top. And these new medicines came out for cystic fibrosis that actually manipulate these chloride channels in the lung and make them work better. The problem with cystic fibrosis is these chloride channels are broken. And so these CFTR modulators, which are these drugs that modulate these channels, came out in about 2018, 2017. And you can see that with these therapies, many people came off the list. And now lung transplant for cystic fibrosis is a very rare thing to do, where it was a very common reason to get a lung transplant in the United States before these advanced therapies. I mostly bring this up to bring up the idea that science is always working behind the scenes. I mean, you guys see all the buildings back here, right? And hopefully one day pulmonary science gets to a point where I'm out of business, right? And that we have therapies that fix lungs instead of transplants that fix lungs. And so this is a really pretty remarkable example, especially a disease that primarily affects teenagers, to have such a dramatic change in our therapies for cystic fibrosis. Here's the age of people getting transplanted in the United States. And one thing you see from 2012 to 2024 is the rise of the 65 plus age cohort. So we've gotten a lot more comfort in doing lung transplants on older people, with now, kind of this older cohort making up almost as much as the most common, which is this 50 to 65 age group. The reason why it's primarily people over 50 is just a lot of these diseases have to do with cumulative exposures over time, whether that's smoking, occupational exposures, and in the case of pulmonary fibrosis, it can be a wide range of things, but most of these diseases slowly progress throughout your decades of life. And so when most people reach the period where they might need a transplant in their sixth, seventh, or eighth decade of life. So it's pretty rare to do lung transplants in this kind of younger 18 to 50 range. And then still in the United States, the most common transplants are bilateral transplants. For every single lung transplant, about 3 or 4 bilateral transplants happen. So, 70, 80% of transplants are double lung transplants, and 20 to 30% are single lung transplants. Yeah, yeah, exactly. Initially, with surgical experience, we were doing more singles because it's a much easier surgery to get through. But as our experience has grown in lung transplant over the last, decade and a half, we've gotten better at the double transplants, making that more accessible surgery for more people. Obviously, the decision between a single and double lung transplant is one of those you guys should obviously have with a lung transplant provider, because it's a nuanced decision on what might be the best surgery for you. It's really an individualized decision.
Why I'm here. And July is having the surgery to see if we get the wheels moving again.
Yeah.
And that's why my breathing is so bad. My diaphragm is not working.
Right.
That helps the lungs.
Yeah. So the lungs are an interesting, I call them sometimes in clinic a pretty lame organ, because all they really are is like a pillow of air, and you actually need muscles to pull air into them and out of them. The heart, if I took the heart, I don't know if this would, but take the heart out, it would beat on its own. Okay. The muscles are intrinsically trained to beat and beat and beat. The lung doesn't have anything intrinsic about it to pull air into it and out of it. It doesn't expand and collapse. It needs those muscles around the lung, which is your diaphragm, and all the muscles in between your ribs to pull that air in and help get it out, And so that's why having diaphragm issues can make it hard to breathe. Is not so the lung can be perfectly fine, but if you're not pulling any air into it and pushing air out, then obviously, it's going to feel like you can't breathe. Yeah. Yeah. And sometimes you can re-strengthen that, and anyways, yeah. Great. So this is kind of like a little bit of the outline of the talk, but to get to a transplant, you kind of have to go through a little bit of a journey. It starts with kind of a referral to a transplant center. Then you usually meet with a pulmonologist to kind of review your history and figure out if this is an option for you. And then you go through what we call evaluation testing, which is this week, 5 straight days, where we kind of put you through the ringer, where kind of looking at your health in every possible dimension to see if lung transplant is a safe option for you. After that, you sometimes have to work on some things, address some barriers. We basically want you to lower your risk for transplant as much as possible, and then we can put you on the list. Okay, listed means we're like looking for organs for you. So we usually don't have that many people on the list because we get people transplanted pretty fast. Then you actually undergo your transplant with a recovery in the hospital that can kind of take 3 or 4 weeks to get over that. And then you kind of proceed to your life after transplant. Okay. And if if you're sitting there and you, I guess we have a lot of people in this bucket here, which is fantastic. So very happy about that. But if you're sitting over here, right, you're asking the question, well, how do I get to there? Right. I mean, that's kind of the main thing you want to figure out. But the way I find explaining this is the easiest is actually to start kind of with the surgery and with the life after so that you understand what it's like to get a transplant, what it's like to live with one afterwards. Because once you understand that, then you get a little bit more of why we have sometimes very strict reasons of why people are or are not a candidate for transplant all the way back to the beginning. So while it might make more sense to go kind of from left to right, I like to start here, talk about the transplant, talk about life afterwards, what it's like to be a lung transplant recipient, so that then you understand why we need all this stuff beforehand. So the lung transplant is the surgical approach is really done usually for a double lung transplant. It's done through this thing that we call a clamshell incision, which goes kind of all the way across your chest, just below the breasts, goes between the ribs on both sides, and then through the bone here in the middle of the chest, which is called the sternum. Okay, this big bone here. So there's nothing minimally invasive about this surgery at all. I want to I, I I am not a surgeon either, so I don't want to like tell you too much about like how this is done in the actual operating room, but it's just important to look at this and go, holy smokes, this is like a huge opening. Okay, most surgeries now are done with some fancy robotic approach with just a couple of holes to try to minimize things, and this is clearly, not that. And this is kind of what the scar commonly looks like after the transplant. And then literally it's I make it sound so easy because I'm not a surgeon, so I don't have to do it. But you're just connecting the veins to the vein, the artery to the artery. That's the blood flow in and the blood flow out of the lung, and then the airway, which is the where the air gets delivered down the trachea through a breathing tube out to each lung. You got to connect that in. So there's kind of three main connections you have to make during the case. And if you do a single lung transplant, it's just going to be one of these. If you're doing a double, it will be both of them. Okay. Combined heart lung transplant is a very rare surgery, usually done for younger people. And in that case, we're talking about they actually do transplant on block the whole thorax. So you keep the heart and the lungs combined, and you just kind of take them out and put them in. An important thing that we don't really need to, I mean, to support you during the surgery because you have bad lungs. So it's like, how do we keep you alive during such a big surgery, so that your body's still getting enough oxygen and you're still getting your carbon dioxide out? The surgeons actually utilize a pump that sucks blood out of your body, puts oxygen into it, and then puts it back in. Basically, does the heart and the lungs job for you while you're doing this big of a surgery. That way, the rest of your organs can stay alive while they're also taking out your lungs. The recovery from this surgery is really hard, and it's a big reason why people sometimes aren't good lung transplant candidates is because you have to be ready for all the rehab it takes, which is why we're all here, right? And all the different things that can happen. Some people spend weeks or even months in the intensive care unit recovering from these when they get complicated. There's lots of infections. Almost everyone's going to get a lung infection during the actual lung transplant just because it's really hard to get the lungs sterile before we put them in. And so it's almost inevitable you'll get a pneumonia afterwards that we have to treat. The surgeons manipulate the heart a lot during the lung transplant. They move it back and forth so they can see certain things. And so when they do that, it induces these abnormal heart rhythms that are common issues. Your other organs can fail, like your kidneys especially. people need sometimes dialysis while they're recovering from these surgeries. Feeding tubes, if you're unable to swallow safely, we can't let fresh food get into the fresh lungs. So we need you to, if you can't swallow, we got to kind of cut that off and just give you food directly into your stomach. And then mood problems with anxiety and depression obviously flare up. I always tell patients that, if I cut off your arm, you would have pain, right? That's like a symptom of the problem, right? If you have a lung transplant, you will have anxiety, okay? It's like a symptom of having a lung transplant. It's just all this illness, your body's in a very shocked and vulnerable state, and the brain's going to take an effect from that. And so we have to make sure all these things are kind of optimized before we put you in for this surgery to make sure, give you the best chance of recovering from all this. These are pictures that can be the case in the ICU, just to give you a sense of the number of drips, the IV drips that are going in, the use of ventilators and life support to recover from lung transplant. And then obviously the walking is so important, but can be very hard with all this equipment that you're constantly attached to as you recover from this. So you get through the surgery, you get through the recovery, and now you get to kind of live the life after transplant. And I think every transplant recipient in the room will know their pencil sheet, like the back of their hand. But the first thing that happens is medications, and there's a ton of them, okay? 3 main medicines help prevent rejection, and they're the top 3 meds on every medical list, okay? Sorry, I should take a step back and say this is our pencil sheet at University of Colorado. This is how all the transplant recipients keep track of all their meds. And it's usually done in pencil. This is typed up by me, so that this is a bad example, but in pencil, because then as doses change or meds change, you can just erase and keep the same sheet running. It just helps keep everything organized. But 3 main meds prevent rejection, but those 3 meds have so many side effects that we're talking about, as you can see, 20, 25, 30 different medications people leave the hospital on often, commonly, okay? Some of these will replace if you're on meds for your lung disease, you won't need those anymore, so some of them may be replaced. But in some cases, if you're on medicine for your heart or for your mood or for blood pressure, those medicines are still going to be needed after transplant. So you're going to be left with these meds in addition to the ones you're on beforehand. Yeah. Yeah, I know. I wish I made it bigger. Tacrolimus is our main go-to. Okay. That's the medicine that kind of revolutionized all of solid organ transplant. Without that medicine, basically no solid organs were basically survivable. Prednisone, okay, which sometimes I know that's how you know you're in a lung leak is when, yeah, prednisone. It starts at 20 milligrams and goes down to 5 milligrams within the first year. Okay, so a year of prednisone, and then 5 milligrams of prednisone for the rest of your life. So it's low dose, but it's still there. And then mycophenolate's another commonly used medicine before transplant for some lung diseases, and we use it after transplant to prevent rejection. Tacrolimus. The dosing, what we care about is your blood level of it, not the dose. Everyone's gonna have to take a different dose to achieve the right blood level. And so what this means is that we got to check blood work all the time to see what the blood levels are, and then adjust your dose based on of what you're doing. So what you eat, what other medications you take, all of that can affect the tacrolimus level in your blood, and therefore we have to kind of constantly be monitoring. Yeah, it's just a tacrolimus blood level. Yeah, but with that, we also get usually a CBC and a chemistry panel, because we also have to monitor for toxicities of these medicines as well. So we're kind of always doing all the blood work at once. That gives us the drug levels and what toxicities could be happening at the same time. Other questions? Yeah.
Is there prescribed medication given for the anxiety or depression that you said is an automatic? I'm sorry, I can't.
Yeah. I tried to put one. I just made this up. So
Okay.
I put one here, just Zoloft. Okay. Most of the mood stable, like meds that are okay for mood, don't interact much with our medications, and so most of them are safe. Some people need more than one, but we have really close collaboration with psychiatry colleagues to help us make sure you're on a good regimen. And then before transplant, which we haven't really talked, when you go through that evaluation week, we also are evaluating that part of your health and trying to start meds or start psychotherapy, before transplant to start getting you ready for all the rigors that it will entail. So it's like we like pre-treat it as much as possible. Then in the hospital, we have psychiatry teams seeing, people to make sure that part's then good. And then post-transplant, we also have the pulmonologist and the psychiatrist helping us out with that. Meds. And then this is just kind of brutal, but I'll be quick here. The meds are really toxic to the body. And there's really no way to, uh, we need new meds that have less toxicity so that these meds can be tolerated for longer. Okay. When you're talking about complications of any solid organ transplant, you're talking about in lung specifically, about half of people are going to die from complications of the actual lung not working and that sort of issue. And half the people are going to die of complications of taking these meds for 5, 10, 15, 20 years. Okay. Because they're toxic to all your organ systems. Okay. Across the board. And it means also that going into transplant, if you have bad kidneys, it's a big problem, right? Because these medicines are going to make your kidneys even worse, right? And so we almost need you to have good kidneys before transplant so we can destroy them in your post-transplant life, okay, with our medicines. Risk of cancers go up a lot, so you really can't have any cancers going into transplant. Diabetes needs to be very well controlled because it's going to get worse after transplant. And then things like all your heart risk factors, coronary disease, high cholesterol levels need to be under good control because those are also going to get worse. And this press and TMA, don't worry too much. This was taken from a different presentation. That's a little more, but there are some rare and very possibly life-threatening complications of these meds too that we're always keeping an eye out for.
I feel like it affects everything.
Yeah. So I'll say specifically lung transplant is the hardest of the solid organs to do successfully. And the main reason why we think that is that the lungs are well, we do small bowel transplants. They're very rare, but lung is really the most common transplant we do where the organ is open to the environment. So it's the only transplant where the transplanted organ sees dust and bacteria and viruses that are out in the world. If I transplant someone's heart or their kidney or their liver, all that organ ever sees is that person's blood. Okay. It has all these barriers, your skin, your lungs, and your intestines to kind of filter out all that bad stuff and only let the good stuff into the blood, and that's what those organs see. But the lungs exposed to the environment. And so it's really prone, it makes it weirdly prone to rejection. And so what that means is we have to use more medicine, more of these anti-rejection medicines to prevent that from happening. But when you use higher doses of those medicines, you get more side effects of those medicines. And so that's what kind of makes it so tricky.
You made it. Why can't they do lung transplant on a cancer patient?
The issue is that cancer is going to start to really grow fast right after the transplant because of all these medicines. Basically, our medicines stop our immune system from working, which is good because you don't want your immune system attacking the new lungs, but your immune system is also attacking these cancers. And so if you stop the immune system, then the cancers kind of have no defense. So we can transplant people with certain cancers, but they have to be treated and in a good level of control or remission. And we're getting better at this. So if you have an underlying cancer and you're interested in lung transplant, I would still recommend you come see a lung transplant doctor, because what I do is I go talk to your oncologist and I look at what's the risk of this cancer coming back, because not every cancer is the same. Obviously, aggressive breast cancer is a different thing than some, or aggressive colon cancer is different than, let's say, a little bit of a prostate cancer, right? Which is much more treatable. Or very early stage breast cancer is very different than late stage breast cancer that's spread a lot of places. And so we have to review the history and figure out what cancers are okay and which ones aren't. This is kind of what I talked about 2 seconds ago, but when you look at what causes, this is what caused death in people who got lung transplants for COPD. So a very specific population who got transplants for COPD. And as you look, this is kind of a busy slide, but the red and the purple bars are causes of death related to the lung issues. And then the green, brown, and blue are related to the meds pretty much. And you can see that as you get further out from transplant, people die of some mix of a combination of issues related to the lung and issues related to the meds. Okay, so meds cause, unfortunately, death after transplant because of their toxicities. And this is kind of what we're balancing in clinic all the time, is trying to keep this balance going where we have enough medicine around to prevent rejection, but not enough that we're having other issues. So kind of by the numbers, so 3,500 transplants are done in the U.S. every year. We did, I guess, 46 in 2025 is what this thing from Dr. Gray says. 18 of our 46 were done in people over the age of 65. So that's kind of supporting this idea that the older people we have good experience with and are ready to handle that. We only had on average, we have about 3 to 4 people on our wait list at any one time. And then a 1-year survival numbers kind of match that in the United States averages, okay? And people on average wait about 1 month to get their transplant at University of Colorado. This was a video. I hope this works. It'd be cool if it did. Did this patient, he came here? Okay.
I wasn't here too long because he lives so far away. He started here and transitioned.
He was featured on Denver 7 just a month ago? And so hopefully this video works. I guess this is where I want to change pace, because I'm just like telling you guys all this crappy stuff. It really is a life-altering thing for the right person, and I think that's really what this video shows. Jeremiah, I'm allowed to share his name because he put himself on television, but he climbed, I think, 3 14ers in the first year after transplant and had a very successful outcome. And so we hope the volume works.
More than 100,000 people are waiting for life-saving organ transplants. That's according to Donate Life America. At one point, Jeremiah Penny would have been included in that statistic until he received a double lung transplant back in 2024. His story comes as the UC Health Transplant Center celebrates the milestone of reaching 10,000 transplants in 2025, with a really special one in the midst of all of that. Lauren Lennon shares that story for us.
I work my lungs pretty hard.
Sometimes it's easy for us to take the small things for granted.
I'm 48 now. At 45, I was diagnosed officially with end-stage COPD, heart failure, pulmonary hypertension, all the things that come along with really bad lungs. Couldn't even walk up my stairs at my house. When I would take a shower, I would constantly in fear of drowning because I wouldn't have enough air to stand there and wash my hair. So even just sleeping, getting out of bed, everything was hard work.
A few weeks to live.
I had 1 foot in the grave.
In December of 2024.
My Christmas came a little early.
Jeremiah Penny received a gift from a stranger that completely turned his life around.
If it weren't for him, I wouldn't be having this interview with you.
A life-saving donation that gave to more than just Jeremiah.
This brought a new life for me as well.
Diana Remick's husband now lives on in Jeremiah.
As my husband was such a giving man, we just had decided that we need to honor his wishes, because if we weren't going to get our Christmas miracle, we were going to be able to give that to other people.
The idea of giving others a miracle is the message Jeremiah's doctors at the UC Health Transplant Center are trying to emphasize.
You get to see people in really bad shape, and then you get to see them regain their life.
Giving the gift of life.
I feel phenomenal. I can do the things that I'm doing.
taking his donor with him every step of the way.
Just got back from California where we did some hiking there. I saw the Golden Gate Bridge. My wife and I were planning on hiking Mount Elbert. So this is our favorite 14ers. I'm hoping to hit that 10-year mark. It's, no reason why I shouldn't.
In Denver,
I'm very fortunate.
Lauren Lennon, Denver 7.
So pretty amazing. In the right person at the right time, at the right stage of lung disease, this is really an incredible treatment for people. And so I try to walk this line of saying how hard it is, because I want, if you're going to proceed with transplant, I want you to be prepared for that. If unfortunately you're told you're not a candidate for a transplant, I want you to understand why this is so hard. But I also want to give some encouragement that, it's something worth going after, and it's worth at least coming and talking to a doctor about it so we can guide you down the right path and get you there if that's what's best for you. Let's see. Yeah.
Tell you, everything is better than facing death.
Yeah. 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 That's a good point. I think that's
So, but the fact, I didn't understand depression. What is there to be depressed about? You're gonna live then?
yeah.
I
Yeah.
don't understand depression, never did.
Yeah.
Everything that you're going through is not at all normal. Because like when I had my heart transplant, I was very active. Walking, doing all this, all of a sudden I cannot cook. I cannot go to the bathroom. I cannot watch. I have no idea if I'm going to live or die because I'm still running risk. I thought the heart transplant was one of the worst. No, the heart, no, the heart, yeah.
Yeah.
But when I'm listening to the lung, that scares me. My son has asthma really bad, and he could drop dead anytime, even if he's on a treatment. Even if what gets me going is my faith in God. God keep me. God is hope.
Yeah.
But even with God as my rich, I get very depressed at times. So yesterday, everybody was barbecue. I said, I have to do it because that makes me feel alive. Otherwise, I just go upstairs and go to sleep. I don't feel alive. So yes, you do get depressed. You get anxiety because especially I have a big family, a lot of friends, they help me, which is great. But then they're not always there. I love gardening it. I got myself a garden at the community garden. Thank God my son took over the garden. I cannot do it. So I go there and watch it. So those cause anxiety and everybody wants to go to heaven, but nobody wants to die. And when you're faced with something like that, it is possible that you are going to die. When the doctors, my heart transplant was my heart bypass was done, I said, "Great, I'll be fine." Then they say, "Well, your diaphragm is not working, so that's affect your lung." So I heard somebody say they couldn't go up. Oh, it's him. Go up the stairs. Going up, my house is full of stairs. Now that I'm having some issue because of the diaphragm, when I go upstairs, I'm out of breath.
Yep.
I can't talk. I don't want to talk on the phone. I don't want to watch TV. I don't want to talk to nobody. I want just to relax. So it is very possible for you to get depression. I got a counselor that's helping me. I have my family. I have my kids. I have a lot, but it's still, I'm going to this road alone.
And I think to answer, I think we all just that's a list of things, but everyone experiences this journey differently, and
Anxious about what's gonna happen,
yeah,
not depressed, because I'm happy that I'm gonna have a little longer to live.
right.
For me, it's difficult.
And so I think that's where it's just having that good relationship with your doctor and with your team, because whatever there's no way, there's no crystal ball I can hand you before transplant or even before you get lung disease and say this is what it's going to look like for you. You know, there's no, I can give you the statistics, I can put up the percentages, but the truth is each individual is going to experience this transplant journey a little differently, and we just have to be ready to deal with stuff as it comes up, you know. So we have like
10.
Yeah, I just did it to give you the 5 minute signal.
oh, okay.
Same thing.
Five is perfect. 5 is perfect. We don't need to go through this. This is just saying how we get you through this evaluation week. And this is a very busy, too many arrows. I wish I could take this slide back. But this is a bunch of testing we do during your week of testing. And the idea here is that once we have this testing, we discuss your case as a group. So this decision of if you're a transplant candidate is or not is too important, I think, for one single person to decide on their own, let alone you need all the different specialties. We need our respiratory therapist from pulmonary rehab. We need our physical therapist. We need everyone contributing to this kind of think about what is this person's risk for a lung transplant, and is that risk too high, is it appropriate, that sort of thing. Okay, and so I'll summarize all of this by saying essentially you do all this testing, we talk about it at this committee, and then we usually can give you a list of things you need to work on before you get on the list, and if you address those items successfully, then we're able to proceed with lung transplant. Okay, if we want to talk more about this at the end, just let me know. And the other thing to mention is that this process, this kind of evaluation for lung transplant journey, can take, on average, I don't know, what do you say? It takes about 1 to 2 months to get scheduled, a week to do the testing, and another 3 months to address any barriers we say. So you could be, from meeting a transplant pulmonologist to getting the lung transplant, is probably around a 5-6 month period. But that journey, like we talked about, is never the same for any one person. Sometimes if it's a young person who's on a ventilator at an outside, I'm over here, can we give them a transplant the next week? You know, if that's what we have to do. If let's say you come into the clinic and you're just an oxygen, you're a little too early, you need to transplant now, we can slow this down. We follow patients sometimes for 2, 3, 4 years waiting for them to get to a point where they need a lung transplant. So this idea that it's 6 months when you meet us is not right. It's really each person gets their own timeline of how long it takes to get a transplant based on the disease and what's going on. Okay. I put this accordion picture in because that's what I tell people in clinic. Things that exclude people from transplant. I won't go too much into these, but these are general requirements at our center that you have to meet in order to proceed with lung transplant. Your body mass index needs to be, less than 30. So you can't be too overweight. Okay, that's a common one. This has to do with wound healing. It really causes infections to happen around the surgical incision, and makes this really severe problem after transplant more common, which is called primary graft dysfunction. You have to be off substances, okay, including alcohol. You need to have all your cancer screens updated. You need to be willing to get recommended vaccines. We optimize mental health before transplants, and you can't be on chronic opiates, okay, or chronic pain meds. Then, of course, you need to participate in pulmonary rehab. And this is mostly what I wanted to get to. So the SPVV, what's involved in it? Do you know?
Oh, the
I know.
SPP
Yeah.
is,
Okay.
Yeah, you can do in a certain amount of time. Do you guys think that we do those like for fun?
Yeah. So frailty is judged by the SPBV, which is pretty much a score at how strong and active you are. Okay. So if that score is low, then you're considered a little bit more frail. And if you're considered frail by that score, what these funny graphs show is that you're more likely to die sooner after transplant. Okay. So the dotted line reflects at 12 months after transplant, and at 4 years after transplant, only about 15% of people had died after transplant if you were not frail, But if you were frail, that is, if you're not strong going into transplant, you're much more likely to die. About a third of people were dead at 4 years who were weaker going into the transplant. And so it's to point out that pre-transplant strength is super important for your post-transplant outcome. Okay, and it's why we send everybody here or to their home pulmonary rehab center to get really, really strong before they go forward with transplant. I think that's it. Our program did a lot in the last 5 years. We've grown a lot and we've done these things. We did our first transplant in a 7-year-old. That's over 6 years ago before I was even here. We did a pediatric lung transplant. We transplanted someone who's an undocumented immigrant. They do have to have insurance. There's ways to get insured if you're undocumented, but we did that back in December of 2023. We performed our 1,000th lung transplant in our entire program in April of last year, which was very exciting. In October of last year, we did our first combined lung kidney transplant. We haven't done a lot of combined organ transplant here, but we did our first lung kidney. And then we transplanted someone with HIV in November of last year. So these are just ways we're pushing the boundary, trying to get, basically the goal of this is we want to get as many people to be good candidates for transplant as we can. And doing these things for first time clearly opens up transplants for people who historically were thought could not be candidates for transplant. All right, I think this is about listing and scores. Don't worry about it. And that's all I got. If you want to talk to our office, here's our number. You can submit a referral at the website. Strength of my scars. This is my one little sales pitch. So Maria is a pretty amazing doctor here. She's training to be a transplant surgeon. Okay, to be a transplant surgeon is 9 years of training after med school. So that's 13 years of training after college, if you can believe that. And she's in year 8. And you can imagine she works very hard, and somehow in her spare time, she makes these fantastic books about certain diseases. Maria Bimas George is her name. She's a fellow, what's called a transplant surgery fellow. And she writes and then draws the illustrations for these books. And myself, Dr. Hoffman, who's our head surgeon here for lung transplant, and Dr. David, one of the other surgeons, we all teamed up and edited this book with her. And it's a nice kind of graphic about lung transplant, what it's like to go through the surgery, what it's like to be considered for, all of the steps I just went through, but in an edible fashion. We need to get these for free in our office, Krista. It'd be crazy. Right now, you go to her website, Strength of My Scars. I don't get paid anything, but she makes a little bit of money, but they're $20 each or something if you want to get one sent. And they have lots of like asthma, COPD. They have other diseases on there too, if you want like an illustrative book to go through certain diseases. Yeah.
We do have a couple of minutes for questions.
Yeah.
In equal, does age factor into you being put on the waiting list?
Yeah. So I think of it as like risk is like a bucket. Okay, and every part of your history and your testing and all these different things add a little bit of risk into your bucket until the bucket, if it overflows, that's kind of where we can't offer a transplant anymore, and age is one of those things going to fill up a bucket, Yeah. So a key part as you get older is that everything else about your health needs to be really good so that we don't overflow the bucket. I don't know if that answers your question. So it's hard to say that one age cutoff alone or one, like if you're 72 years old, you can't get a transplant, but if you're 71, you can, because it's really about it's really that individualized approach, which is kind of adding all that risk together. I think the oldest recipient we've done was around 77, 78, 76. And like we've shown, got a more and more experience with doing older and older recipients. So the amount an age adds in may be getting less because we get more experience with it. But yeah, it's hard to say concretely what's the number. Yeah.
When a donor becomes available, what is on the list that has to be matched between the donor to get a recipient together?
So the only things we care about in lung is your general height needs to be the same because everyone's lungs are the same, are different sizes. Okay, we probably see that in our pulmonary function tests, but everyone's lung size is going to be a little bit different based on your height. So we have to match the height so you get the right size lung for you, and then blood type. Okay, and then we can check this kind of. Some people gain immunity to other people in the world for various reasons. And so we can check your blood to see if you're immune to other people. Just like you can be immune, like a vaccine gives you immunity to a virus, you can, if you get a blood transfusion, you get another solid organ transplant, or you deliver a child, it turns out you're exposed to another human's blood. And so you develop immunity to other people out in the world. And so we check your blood to make sure you're not immune to your donor. Okay, so this immunity measure, height, and blood type are the three things. Gender doesn't matter, and other things like race doesn't matter. Yeah. No. You think about bone marrow transplant is a totally different game. I think that's where some people draw their brain to, but bone marrow transplant, you have to be matched like 12 out of 12 on the super rare thing. That's why they make that registry where, they call people from across the world to be a bone marrow. In solid organ transplant, we don't need to be nearly as close as in the bone marrow world. Yeah. 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 It is. Um, I'm just going to be honest. I don't know the answer of why Europe does so few less. Yeah, I don't know what, and it probably is higher up now if you look at 2024 and 2025. I just don't know why, because I personally know people who practice in Europe and they have excellent pro. It's not like if you had lung disease, it's like don't go to Europe. I mean, they clearly are experts at it. I don't know if it's just a matter of population not being as high overall, especially in some of the more developed European countries like in France, Spain, England. But possibly, I just don't know the answer why. It's a good point. I almost wish I would have just shown you the American one. That way I wouldn't have to do it. But yeah, I don't know why there's so few done there, like where that experience came from. A big chunk of the transplants done are in Canada too, in North America. That's an important thing. University of Toronto did the first lung transplants in the world, and they're kind of like the pioneers for lung transplant. And so they do a lot in Toronto compared to other countries. Yeah.
How do you come across PTLD?
It's a good question. It's kind of in that. Do you see that when I said the causes of death after, that malignancy category? Probably about, I don't know the exact stats, but if I were to ballpark it, probably about, half of cancers after lung transplant are associated with PTLD. And PTLD is a specific type of cancer that's due to the meds. Okay, it's due to the immunosuppressive meds, and it's obviously more common in lung transplant than other solid organs because we use higher doses of meds for longer periods of time. But it's probably half of that bar, so it is fairly common.
Have you seen a lot?
We do, yeah. And we're currently revamping some protocols to make sure we're keeping an eye on this EBV virus, which is important to PTLD, so that we don't get too far behind it. It's a treatable type of cancer when caught early, obviously, and it's harder to treat later. So it's one of those kind of, if we can catch it early, we can prevent complications. Yeah. 33. I think right now it's 33. We just had the newsletter go out and it says every person's in our program, I think, right? In all the years. I think it's 33. I know. Well, that's the other thing. So our roles in this relationship are so different. My job is to worry about how do we make lung transplant better as a whole, you know, and that's about averages and statistics and stuff. Your guys' journey is a 101, you know. I mean, so you don't care, you don't have to be average. You're a one data point on the whole thing, and yeah, and it is going up. Yeah, 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 it is. It is. Hopefully we can make it continue just to get better and better and better at it. Yeah. Oh my God. Such a good question. And such a relevant question. So I answer this one more often in my ILD clinic than I do in the transplant side of things, you know, but we don't think so. Okay. It's actually a pretty hard question to answer because there aren't many centers at elevation. We're one maybe. Okay. I think Salt Lake might be at some elevation, but we're really the highest lung transplant center in the United States and the longest pulmonary fibrosis center in the highest pulmonary fibrosis center. What we've done is we've compared two groups of people, one here and one in San Francisco, and we watched them together. Okay. And the ones in San Francisco and the ones here their lung disease progressed at the same speed. Okay. So you need more oxygen at altitude for sure. There's just not as much in the air here as there is at sea level. But we don't think that causes your lung disease the trajectory of your lung disease to change, if that makes sense.
Able to do better at sea level. That doesn't necessarily make a difference in progression.
Right. Well, one, if you feel better, you might exercise more, have better quality of life, your mood might be better, and that could make you live longer, you know. But what I'm specifically talking about is if I look at the lungs themselves, like the degree of lung scarring, is that scarring getting worse at elevation or at sea level? Probably not. You know, but there's so many other things that are better at sea level if you have lung disease, like just your breathing feels better, which results in better quality of life, keeping your weight up, all these things. Don't need as much oxygen, exactly, more likely to leave the home and things like, just all these things play a role. And so those may end up, yes, affecting how long you live with your current lungs, but probably the actual lung disease inside the lungs is the same, at elevation or yeah. Good question though. Very common here in Denver. Other questions? That was fun. Thank you. Yeah. Thanks for having me.
Okay, everybody, really quick, we're gonna close the house before everyone leaves. Thank you again.
Yeah, of course.
Amazing. All of those of you here who
is irrelevant. I'm just curious where you went to med school.
UCLA.
That was only a lot.
I grew up in Los Angeles. It's where my parents were. That's where I was born. But yeah, and then I did the training at Northwestern Chicago. It's like training in San Francisco. But, yeah.
You know what? Okay, so they need to be clear.
Yeah, I did. Great. Yep. Oh, sorry. I'll hang up for a minute.
So the meeting, like Jim said, if you could fill it up, maybe the table. Next month, June 30th, we are behavioral health, and the hormonal tag. The hormonal performing next month, so please be here for that. There are flyers also on the table for the donor dash. That's July 19th. Here's what the flyer looks like. If you want to fill out, or if you want to grab one of those, I think that is everything again. Thank you all for being here. I know how much it takes for us to get up and get out and be somewhere. So thank you. And thank you to the caregiver for the coach.